Afternoon, everybody. My name's Stephen Jones. I'm one of the ear, nose and throat consultants in Dundee. I'd like to thank the college for asking me to moderate this session. I'd like to introduce Emma Stapleton, who is one of the ENT consultants and skull-based surgeons in Manchester. And she's going to talk about cranial nerve palsies and their management. For those of you who haven't been to any of these sessions before, we'd like you to ask questions using the Q&A facility that you'll see at the bottom of your screen. During the talks, if you see any questions that you think are interesting that you want to see answered, then what we'd like you to do is to use the thumbs up button to vote for them. And at the end of the session, we will have 10 minutes to talk about the questions that have the most votes until we run out of time. So this session will be recorded and it will be available as a link through the college website later on. So let's introduce Ms. Stapleton and start the session.
Great, thank you, Stephen, and thanks everyone for logging in. I'm going to speak to you about cranial nerve palsies. So as medical students, which I think most of you are, you'll be very familiar with the very complex anatomy of the skull base, which I think is beautiful, but you may not associate it with ENT, and I am an ENT surgeon. And so I'm going to start with my usual plug for ENT as a career by telling you that ENT isn't all about snot and earwax, it's actually about the cranial nerves. And although that's a very complex topic, which we'll only get a flavour of today, I hope I'll be able to give you sufficient taste of it that you'll be more interested going forward in ENT as a career. So I'm part of a very big skull-based team in Manchester. We have a lot of members of our team, and the reason for this is that cranial nerve disease is very complex and we need a lot of very experienced professionals to provide our patients with optimal care for their cranial nerve disease. So as you guys will already know, the cranial nerves come in 12 pairs. They all arise from the brain or brainstem. They don't come via the spinal cord, and their anatomy is complex. Their pathophysiology is complex, and the clinical pictures that they produce when they cause problems is really complex. So this really is going to be a bit of a whistle-stop tour. We're going to speak about why cranial nerve palsies are important and touch on the surgical sieve in terms of how to approach looking for pathologies. We'll then talk about how to examine the cranial nerves and identify a palsy, and then touch on some investigation and management via some interesting clinical cases. Skull-based lesions are pretty rare, but the clinical cases I'm going to present are all ones that we've managed in the last few weeks, so they're all very current cases. So before we start, we're going to have a light-hearted poll, and hopefully you're going to let me know what your favourite cranial nerve is. And we'll do the same at the end of the session and see whether you've changed your mind. You've got 30 seconds to vote. Great, so, oh, well done, guys. Okay, so the facial nerve is the winner, trigeminal nerve is a close second. Nobody's voted for the 8th nerve, which I'm really disappointed in, so hopefully, perhaps by the end of this, we'll have some votes for nerve number 8. Okay, so why are cranial nerve palsies important? Based here, what the cranial nerves do, and this is actually a simpler, reality is even more complex than this. And just by glancing at this slide, there are a number of sensory functions, which I've put in yellow, a number of motor functions, which I've put in red, and there are some sympathetic and parasympathetic fibres that feed into these cranial nerves as well. So they really do have complex functions. And if you just cast your eye over what they do, these are senses and these are functions which define who we are and keep us alive. And hopefully by wrapping your mind around that, you can understand why any deficiencies in a cranial nerve can have a really profound effect on patients' lives and their quality of life. So I'm sure you're all familiar with the surgical sieve. This is the one I quite like, and I think it's quite nice to keep thinking about these in order to simplify and to focus on how we're going to address the pathologies we're looking at. So just to drill these down before we get going, do vascular causes cause cranial nerve palsies? Yes, very much, but this is normally in the context of a stroke. And in fact, if a patient has a cranial nerve palsy secondary to some sort of vascular accident, they'll go down the stroke pathway, and it'll usually be the stroke that's the predominant picture rather than the cranial nerve palsy. I've highlighted infection and inflammation because these are probably the commonest causes of cranial nerve dysfunction, and they're actually the least disabling as well. They're often temporary, although not always. And they're the ones that you'll see frequently in an ENT clinic, usually in the form of a post-viral loss of smell or a viral facial nerve palsy, which we know as a Bell's palsy, which tends to recover over time, but not always. I've also highlighted trauma. It's really important to take a history of trauma in patients who come in with a cranial nerve palsy. These are nerves which go through the skull base, and actually trauma to the skull base, especially fractures, and also just swelling or bleeding around the skull base can cause dysfunction of the nerves. There are autoimmune and metabolic. These are less common, and they're usually apparent from the patient's history. Iatrogenic cranial nerve palsies usually come with a history of recent surgery, so we're not going to touch on those, but that's something important to touch on when you're taking a history. Neoplasia is another one I've highlighted. A lot of skull-based lesions knock out cranial nerves, and these can be benign or malignant, most often benign, and the malignant ones can be primary or secondary, and I've got an example of a secondary one coming up later. Congenital cranial nerve palsies have been present from birth and won't normally present to you acutely. Degenerative causes of cranial nerve palsies are fairly common, especially in terms of vision and hearing. But again, these will normally be apparent from your history, and they're not something that will generally give you a confusing presentation. Finally, functional cranial nerve palsies are a problem to some of our colleagues. There are patients who present with cranial nerve symptoms, but who don't have a recognisable pathology. And functional is generally defined as a diagnosis of exclusion. A couple of other things to think about when examining a patient with a cranial nerve palsy: is it complete or incomplete? As a general rule, complete cranial nerve palsies have a poorer prognosis. And also, patients will want to know, is it temporary or permanent? And this is another really important thing to touch on in terms of the natural history of cranial nerve palsies. If your cranial nerve is injured, it's very unlikely to ever regain its full function again. In fact, when the facial nerve is taken out and we graft it, it never gets back to what it was previously. It's never as good as the original cranial nerve. So this is an important thing to think about when you're assessing your patient. Actually, just in the last few weeks, there's been a new development in cranial nerve pathology, in that the UK has added loss of smell and taste to the list of diagnostic features of COVID-19. And I suspect this has changed the environment of patients presenting with anosmia quite significantly, in that previously they would undergo a number of investigations, whereas now the vast majority of them will be presenting with COVID-19 with their loss of sense of taste and smell. So we don't have time today to go into detail about anatomy. I just want to touch on the fact that cranial nerve anatomy really involves your neuroanatomy and your osteology together. And I know there are currently some really nice 3D simulations that you can use to learn. But if you can somehow learn both of them together, it can really help you understand things clinically. So whilst you might be familiar with looking into the base of a skull and naming the foramina, and you may be familiar with looking at the base of a brain and looking at the nerves, you try and put them together in your mind. It can really help you clinically. An example would be an isolated sixth nerve palsy will often present as part of petrous apex disease. And if you can imagine, this is the sixth nerve, and it comes out just where the petrous apex is. That's the apex of the temporal bone. So when we're identifying a cranial nerve palsy, the presenting plate is really important. Often your patient will present with their cranial nerve palsy. They'll come in with their facial palsy, with their hearing loss, with their loss of smell, and they'll tell you exactly what the problem is. But it's still really important to take a history, especially with a history of trauma, infection, and past medical history. In terms of examining cranial nerves, I'm going to run through that very briefly, but the important thing for you guys is to practice, practice, practice. And that can actually be a lot of fun if you have a friend or a partner that you can practice with repeatedly. If you come to a clinic and see one of us examining cranial nerves, it's literally over in seconds. We've done it so many times, it's very slick and very quick, and we pick up what we want to very quickly. Finally, investigations. There aren't a huge array of investigations we do, but the vast majority of patients presenting with a cranial nerve palsy these days will get some sort of imaging, usually an MRI scan. So we're now going to go through the nerves in turn. Firstly, the olfactory nerve we mentioned earlier. You need to ask your patient whether they've noticed any change in their sense of smell or taste. History of head trauma is really important because fractures through the cribriform plate can divide or cause swelling around these olfactory fibres and cause a loss of sense of smell. Onset during viral illness doesn't just apply to COVID-19. In fact, viral loss of sense of smell is one of the commonest causes. You do need to currently ask about coronavirus if you meet a patient with anosmia, and degenerative conditions are also important. It's well known that patients with dementia often have a loss of sense of smell. MRI scans are very easy to access these days, and therefore the majority of patients with a loss of sense of smell will end up having an MRI scan. This is to look for any abnormal lesions of the anterior skull base. In terms of objectively testing the sense of smell in the clinic, there are some standardised tests you can use, but you can also use easily accessible things such as coffee, lemon, chocolate, and just ask your patient whether they can tell the difference between the smell of them. Cranial nerve 2 is the optic nerve. This really belongs to the ophthalmologists, but if a patient presents to you with a sudden vision change, it's essential that you do a very basic examination which includes visual acuity with a Snellen chart, visual fields, pupillary reflexes and fundoscopy. If they do have evidence of acute visual loss, they need to be managed urgently by an ophthalmologist who will do a complete assessment and probably an MRI scan. We've lumped cranial nerves 3, 4 and 6 together because these are the ones that move the eyes. Patients with a palsy of one of these cranial nerves will usually present with a complaint of double vision, and it's when you go to examine their eye movements you'll notice that they aren't quite right, and that's why they're getting their double vision. Fourth nerve palsies are nearly always congenital, so they won't present acutely, and as we mentioned earlier, sixth nerve palsies are the commonest acquired cause of a problem with the eye movements. You'd worry about cavernous sinus thrombosis or any other lesions in that area, and they would most definitely warrant an MRI scan. The trigeminal nerve, which scored second in your list of what's your favourite nerve, is a really great nerve. It does a lot of stuff. It has a sensation component with 3 branches, and it's really important to examine both pain and soft touch in the clinic to look for abnormalities. What we tend to see is that patients who've had an injury to their fifth nerve or invasion of a tumour to their fifth nerve will have numbness, so the sensation is gone. And patients who have something pressing on their fifth nerve will generally present with a pain in their fifth nerve. The fifth nerve also innervates the muscles of mastication, so you can examine those in the clinic too. And once again, if patients have some deficits in their trigeminal nerve, they nearly always get an MRI scan. Facial nerve is your guys' favourite nerve. It is a pretty good nerve, and it's the one you'll most commonly see a palsy of. If any of you have done a job in A&E or GP or ENT, you will undoubtedly have seen a facial palsy. It's really important to ask about a history of head trauma. Often patients who've hit their head won't necessarily volunteer that information unless it's acute. And what we see with facial palsies is often it's the swelling following the injury that causes the palsy, so they might present sometime down the line. So you need to ask about head trauma, you need to ask about other symptoms. You can grade a facial palsy from 1 to 6, that's really beyond the scope of this lecture, but it does tell you something about their function, and it tells you whether you need to look at their eye condition. Patients with a House-Bratman grade 4 to 6 will not be able to close their eye on the side of the palsy, and you need to look after that eye. You need to give them some tape to close it, some tears to use at night, or they'll get a very dry, painful, ulcerated eye. If we think about the anatomy of the facial nerve, it's also really important to look for any lesions in their ear. We know the facial nerve runs through the middle ear, and the parotid, both externally, and looking at the pharynx for the deep parotid lobe, which is a site of tumours which can affect the facial nerve. Once again, if patients do have a facial nerve palsy, they'll nearly always get an MRI scan. The exception would be in acute trauma, when a high-resolution CT scan can be really useful for looking at fractures and swelling around the facial nerve. The eighth nerve, I'm disappointed that nobody voted for it because it is the nerve that I deal with the most. It's a special nerve because it is a single cranial nerve that supplies two distinct senses, hearing and balance. They arise from the same nerve, but they do different things. Hearing loss is very common. If patients present with a sudden hearing loss, this is a pure tone audiogram with an asymmetry in the hearing. And actually, if you go and do an ENT job, it's asymmetry that you'd be trained to look for. And if someone has an asymmetric hearing loss, they generally get an MRI scan. But it's important to ask about other symptoms as well. Dizziness and tinnitus go hand in hand with ear disease. Again, you want to ask about a history of head trauma. And if you see a patient with a 8th nerve deficiency, they'll nearly always get an MRI scan. Cranial nerve 9 is the glossopharyngeal nerve. This really goes hand in hand with the 10th nerve. These are what we call lower cranial nerves, and they run closely together through the jugular foramen. And often you'll see the palsies of the two in association with one another. But when you're examining the 9th nerve, you want to look for pharyngeal symmetry, pharyngeal sensation. An important thing from the point of view of the patient's quality of life is whether they're swallowing safely. Are they at risk of aspirating? And if they are, you'll need to involve your speech and language colleagues and modify their oral intake appropriately. Again, MRI scan. The vagus nerve is the 10th nerve. As we saw from our chart earlier, this nerve does a huge amount. In ENT, we usually see it presenting with a weak voice because of recurrent laryngeal nerve palsy. Recurrent laryngeal nerve, you'll remember from your anatomy, comes from the brainstem right down into the chest and back up into the neck to supply the larynx, and it takes a slightly different route on the left to the right. If a patient comes in with a weak voice, we can very easily do a flexible nasal endoscopy in clinic, and it'd be nice to have a moving picture. But what you generally see is one vocal cord moving normally and the other being paralysed, which gives them a weak voice because they don't meet in the middle. Again, you want to know whether their swallow is safe. You'll involve your speech and language colleagues. You want to examine their neck. Are there any lumps or tumours that could be knocking out the nerve and giving them their vocal cord palsy? And these patients will warrant an MRI head and neck, but also a CT scan of their chest. The accessory nerve is the nerve which moves the muscles of the neck and shoulders. When you're examining these, you need to examine the movements of the neck and shoulder against resistance, and also examine the neck carefully for lesions. This is actually a very commonly injured nerve during surgery or trauma to the neck, so it's important to take a history for those. Finally, the 12th nerve. It's a nice classic picture here. You need to ask about recent trauma or surgery. Ask them to protrude their tongue. As you know, if a patient has a 12th nerve palsy, it deviates to the side of the lesion, and the affected side of the tongue will be wasted and often have fasciculation, which is a sort of twitching of the muscle fibres of the tongue. And again, these patients warrant an MRI of their head and neck. So that really is a whistle-stop tour, and cranial nerve history and examination can be really, really complex depending on how deep you want to dive down that rabbit hole. And what I would encourage you to do is to just keep it simple in the first instance, practice with your friends, and pick up different bits of information as you go along. And if you're genuinely interested, then please come along to some skull-based clinics. We'll be delighted to show you how it works in real life. So I've got some clinical cases to finish off, just to show you how it presents to a skull-based clinician. This is a 75-year-old patient who had a history of prostate cancer, and he presented to his GP with difficulty swallowing and a weak voice. Now that raises a concern about lower cranial nerve palsies. When he was assessed by his local ENT surgeons, he actually had a facial palsy on the left and a vocal cord palsy on the left. Actually, by the time we got hold of him, he'd also lost his hearing and balance. So this is something that's knocked out cranial nerve 7, 8, 9, and 10. Now, he couldn't have an MRI scan because he had a metal foreign body in his eye. And this is a CT, and you might not immediately see the abnormality, but if we look for symmetry, this is the skull base, and this is the occipital condyle on the normal side. And if you look on the abnormal side, the occipital condyle has been completely eroded by this big lesion here. Now, the radiologist said this is either a metastasis or a paraganglioma. I biopsied this and it came back as prostatic carcinoma. So this was a prostatic carcinoma metastasis in the skull base, which knocked out cranial nerves. And here's an example of why it's really important for surgeons out with ENT and neurosurgery to know about cranial nerves as well. Clinical case 2, this is a very young lady who presented with double vision and had palsies of cranial nerves 3, 4 and 6 on the right. She was initially seen by ophthalmology and sent for an MRI scan, which has shown some enhancement here. This is a cavernous sinus. From your anatomy, you'll know the nerves and vessels which run through that. She's actually still under investigation, but I think this is a really interesting scan, which really pinpoints where her pathology is with such a presentation. This is a 52-year-old gentleman. He presented with palsies of cranial nerves 10 and 12 on the left. So he had a weak voice, he had tongue wasting on the left, he had an MRI scan of his head and neck, and this shows an abnormal lesion, which I'm sure you can all see, centered on the left jugular foramen. This is a paraganglioma, or you might have called it a glomus tumour. Here's a coronal image where you can see it indenting the brainstem there. And you can imagine how that's knocked out some of these lower cranial nerves. So paragangliomas are a massive topic on their own, but suffice to say, they require a bit more investigation. He is having further imaging to look for any other lesions in his body and referrals to endocrinology and genetics to find out whether there are any associations. Clinical case 4 is one we're going to operate on very soon. This is a 45-year-old man who presented with a gradual loss of hearing and balance on the left. He's otherwise well. He had a putanologogram which demonstrated asymmetric hearing loss, and his imaging shows this. So we see these all the time, but I appreciate it's not as obvious to you guys. So this is an axial MRI scan. This is the brainstem, this is the cerebellum, and this is a normal inner ear on the left with the 7th and 8th nerves going through the internal auditory canal. And if we look on the right, these normal nerves are replaced by this big, it's about 3 centimetres, tumour in his cerebellopontine angle. Cerebellopontine angle is the angle between the cerebellum and the pons. And the significant thing about this tumour is that it's pressing into the cerebellopeduncle. He's a young man, so radiotherapy is not particularly an option. In fact, radiotherapy wouldn't be a great option anyway, because it causes swelling of the tumour, which might have a detrimental effect on his brainstem and cerebellum. So he's opted for surgery, and that's major surgery, the aim of which will be to completely remove the tumour. Here's a similar one. This is a 40-year-old man who presented with hearing loss and imbalance. His MRI scan shows something quite different. This MRI scan has got some contrast, which is why these things are glowing white. He's got bilateral vestibular schwannomas. So these are his internal meatuses on both sides, which have tumours in them. And bilateral vestibular schwannomas in the presence of multiple meningiomas is diagnostic for a condition called NF2, which is a genetic condition which causes lesions like this, and it's very complex to manage. So there are just 4 centres in the UK that look after these patients, and if you ever visit, you can refer it onto one of those. Last one, clinical case number 6. This is a 35-year-old man who presented with a right-sided facial palsy after a head injury. His facial palsy was complete and it was immediate. He had a CT scan in the emergency department which demonstrated a comminuted fracture of his temporal bone on the same side. So you can see here, this is a CT scan. It's an axial cut. On the normal side, you can see some air in his mastoid air cells. And on this side, you can see the bone is broken up and there's no air. That's full of blood. And the fact that the facial palsy was complete and immediate means he warrants probably exploration of that facial nerve. And this will be a case to refer urgently to your local ENT colleagues. So I feel like I've really only just scratched the surface, but suffice to say that cranial nerve palsies are a really, really complex topic. When you meet a patient with a cranial nerve palsy, you've got to take a very careful history, examine them carefully, and communicate very closely with your radiology colleagues as well as the relevant specialties, because they will help you out with these complex cases. Another point to add, which I think is really important, is to always think about your patient's quality of life as well as their pathology. So if you've got a patient who's got a cranial nerve injury or palsy, just take every step you can to make sure that the trauma to them is minimised while they go through their treatment. So we've got our poll coming up again. I'm hoping the 8th nerve will get a couple of votes this time. Yay! Great, so you still like the facial nerve the best, but the eighth nerve has gone up and the trigeminal nerve is still up there. Great. Okay, thank you guys. I'm ready for any questions you've got. You're muted, Stephen. I can't hear you. Oh, got you.
Sorry about that. I keep trying to unmute myself, but there we go. Thanks very much, Emma. I've got a few questions here. The most popular one of all, by quite some way, was from an anonymous member of the audience who asked how you differentiate loss of balance due to a cranial nerve 8 lesion and loss of balance due to a cerebellar lesion.
Oh, yeah, that's a great question, actually. So that's something that we face a lot, I'm sure you do as well, Stephen, in the balance clinic. So as ENT surgeons, we get a lot of patients referred to us with balance problems, and a lot of them are automatically referred to ENT. In fact, you can tell the difference between the two types of imbalance from taking a history and even from the moment your patient walks in the room. So patients with a cerebellar lesion, they'll be veering to one side and they'll be very staggery and imbalanced. Patients with an inner ear lesion, often it's intermittent, so they might walk into your clinic very normally, and it's only when you examine them you'll find some subtle signs of inner ear type of dizziness. It's a really massive topic on its own. Yeah, if you're genuinely interested in balance clinics, I think you'd be very, very welcome to attend one, because we're delighted when someone shows an interest in it.
Thanks very much. I've got a question specifically about one of your clinical cases. Nadia Nasaruddin had asked, in your case number 4, you had an MRI image that showed a tumour on the right, but they said that the reduced hearing was on the left. I'm not sure whether you are able to get the images back up and show whether
I can try. That might be my...
There we go.
No, that's me being a numpty. His hearing loss is definitely on the right.
I have to point that out. So there's another question I've got here, which asks about nerve conduction studies. It asks, Umesh Harshana asks whether nerve conduction tests can be applied for cranial nerve lesions.
Okay, yeah, that's a good question. So it's not something we use frequently, but it is something that we occasionally use for facial nerve lesions. Essentially because facial nerve is a facial nerve injury can be very disabling, and we want to do everything we can for our patients with a facial nerve palsy. Also, it's a motor nerve, so it's fairly easy to test its motor function. The circumstances under which we use it, I don't know about you, Stephen, we don't use it very often, I have to say. If we've got a patient who has a persistent facial nerve palsy and we have done some imaging which shows that the nerve is intact, we'll often do conduction studies to ascertain whether the nerve is intact and therefore likely to recover, or has no conduction at all, in which case we're going to think onwards about how we rehabilitate that patient's facial function.
Thanks very much.
I've not used it for any other cranial nerves, have you?
Not that I can remember,
No.
Not in the recent past, certainly. I've got another question. Can an NG tube ever cause damage to cranial nerve 1?
Ooh.
Is that something you've ever come across?
No. No. I mean, I guess the general teaching with NG tubes is you need to push them back rather than up. We've all seen patients with nosebleeds who've come with packs that have been pushed up rather than back, but I've not yet seen a patient that's had a loss of sense of smell due to them.
I think they'd have to be pretty vigorous with their nasogastric tube to do that, wouldn't they?
I think so.
And I think we've got time just for one last question. Richard Mifsud had asked, can surgery remote to the brain, such as colon surgery, lead to cranial nerve palsies? Have you ever come across that?
No. So I've only come across remote disease in the skull base in terms of metastases. I have seen a colon metastasis in the skull base, but not surgery in itself.
No. Okay, well, I think we only have until past, which means, unfortunately, we're out of time. I've hopefully answered some of the other questions as we go by typing, but we've run out of time for all of them. They're now flooding in. But, thanks very much, Emma. And just a reminder to the audience that if anybody wants to watch this back later, it's been recorded and we post it up onto the College of Surgeons of Edinburgh website in the very near future.
Thank you.
Thank you.